So good afternoon, everyone. My name is Harry McMillan, one of the directors of Momenta Newcastle, the provider of the Type 2 Diabetes Path to Remission service in Cheshire, Merseyside. And I'll be taking you through some details of the service along with others, particularly John Scott, who'll be talking through some of the practicalities, and Chong Ui, who'll be talking through the medication adjustments. I'll be driving the slides, so any problems with that are entirely my fault, and hopefully it'll be reasonably smooth. Okay, thank you. As I say, any questions along the way, please put them in the chat. So this is what we'll be covering. A brief introduction to the service, some of the background to it and some benefits of it, a bit about the program itself, bit around the roles and responsibilities between yourselves in primary care and us as the provider. Then talking about the medications adjustment, so deprescribing and potential for subsequent retitrating. And also after that, some referral support that is available to you that we've been working on with the ICB. And then next steps. And I should have said before we start that I'm not a clinician, but we have been delivering the service for a long time, so I'm going to be covering off aspects of it. If there's any questions around the any clinical queries, then I'm sure that Sean can address those, and failing that, we can always get back to you if we need to consult on anything. So in terms of the service, it's based primarily on the DIRECT study and also with input from Droplet. DIRECT was the first study of its kind that showed that remission of type 2 diabetes was possible at scale in primary care settings, and it was conducted by the universities of Newcastle and Glasgow, sorry. And I say that. It was also, obviously, you've got your own local experience of showing that remission is possible through primary care at scale, but that takes a more food-based approach, low carb approach with David Unwin, not the approach that is taken here, which is based on DIRECT, which is a total diet replacement approach. The two aren't competitive; they're two sides of the same coin. So this service is based on those studies, and that's the reason that it takes the form it does. In DIRECT, many of you might know that the intervention group, about a quarter of them lost 15 kilos or more at 12 months. So that's that's a very significant amount of weight loss for a lifestyle-based intervention. And of those, of the intervention group, almost half achieved remission of their type 2 diabetes, and that dropped to about 35% at 24 months. And there were fewer adverse events in the intervention group than the control group. So NHS England, with some support from Diabetes UK and others, looked at this and thought it was worth developing this service first as a pilot and now as a framework. And what they also found in DIRECT is that remission is very closely linked to weight loss. So the higher the degree of weight loss, or in fact the absolute weight loss and also percentage, the higher the chances of achieving remission. And remission in DIRECT and also for this service is defined as having an HbA1c of less than 48 for more than 6 months and on no diabetes medications. Now, that means that some people, as you'll see from the medication adjustments guidance later, it means that some people who start this service will not be able to achieve remission, at least while they're on the service, because they will still be on some medications. But there are significant benefits beyond just the possibility of achieving remission. So from a patient point of view, the weight loss is probably the single greatest benefit, because that has impacts on a range of different comorbidities, as well as helping people achieve remission potentially. But as we can see from DIRECT, even in a more controlled population, only half the participants achieved remission. So if you take that as a guide, the concept of remission is important, but it shouldn't be overriding for your patients, because otherwise you'll be setting a lot of people up for disappointment. But they should expect that if they stick with the program, they can achieve really quite significant weight loss, which can have a range of other benefits, as you can see there. We've got lots of case studies, which a lot of people, when they talk about this, yes, some of them are very focused on achieving remission, and many are focused on the weight loss, but so many of them actually find that some of the other aspects of weight loss and associated factors are the things that they actually are most excited about and mean the most to them. So I'd strongly encourage you to have a look at some of the individual case studies and see the human impact of the service rather than just the numbers. So in terms of practice benefits, it's a free service because it's been commissioned by NHS England. I say free in the sense of there's no cost to the practice. Eligible referrals can qualify for the weight management enhanced service fee. That's not all referrals, but if they meet the criteria for the weight management enhanced service fee, then referrals to this service will qualify for that £11.50. And probably more importantly, anecdotally, we've heard that practices benefit from seeing from successful patients visiting less often. So probably again, this is anecdotal, so it's not straightforward to quantify, but probably because of the impact on comorbidities and the need for such frequent support from the practice, and even the feeling of the need for such frequent support from the practice. So, and finally, I should say that although we'll come on to the work involved in practice in a second, but we and the ICB will provide significant support to you to help make referrals. So just very briefly, in terms of the framework, it was piloted as the NHS low-calorie diet programme from 2020 in up to 20 ICBs. We started off delivering in Birmingham and Solihull, and then added another couple over the course of the next year. That pilot has similar emerging results to Direct, and NHS England made a national framework as a result of that. So very similar to what they've done with the NHS Diabetes Prevention Programme. So there's a framework of 5 providers, of whom we're one, and then they are selected on an ICB basis, and you very kindly selected us. It's designed very similarly to the Direct study, and I'll show you that in a minute. So we are your provider in Cheshire and Merseyside. We're Memento Newcastle, or Memento for short. Newcastle is in our name not because we're based there, but just because it's a kind of a nod to the great work done by the University of Newcastle team, who also contributed to the design of our service, so the Direct team, which we're very grateful for. So now we're working in 13 ICBs, and the closest ones are probably Greater Manchester, Birmingham, Solihull, South Yorkshire, and then a fair few others. And our early outcomes are also in line with the NHS England pilot and the Direct study. So depending on the demographics, there's a 11 to 13% weight loss at the end of the first phase, which we'll come on to the phasing in a minute, and that's maintained into the third phase. And there seems to be a positive impact on the health inequalities in that we have a very significant proportion of people from the lowest IMD quintiles referred to the service and who started and take it up. The service in Cheshire and Merseyside officially launched on the 1st of April, but this is the first event to talk about it at scale. There have been some other events where the programme has been discussed, but this is the first one to support the referrals to it. And thank you for coming to this, and also for interest from yourselves and many of your colleagues. So in terms of the programme, it's 3 phases over 12 months. It's all free to participants, including the TDR, or Total Diet Replacement product. So the first phase lasts for 12 weeks, or 3 months, and on that phase, your patients will be replacing their real food, normal food, with 4 Total Diet Replacement products per day for 3 months. So that's soups, shakes, and porridges. Then after that, they will move into the second phase, the food reintroduction phase, which is where they replace one of those products with real food for 1 main meal every 2 weeks. So it's a phased introduction or reintroduction to real food, and it's quite structured because that's the point which many people find very challenging and are most worried about. And then the third phase is where it really brings in the kind of healthy eating advice and physical activity uptake, and so to bring those healthy habits into normal life. In that third phase, if patients put on more than 2 kilos from their lowest weight, they become eligible for a reset or rescue package, which is up to a month of TDR product, again, to basically give them that nudge to kickstart it back again. The framework delivery is all one-to-one, and it's patient choice of either in-person clinic or digital supported by an app. But both formats are supported by coaches. The TDR product we use, the supplier is called Habitual, and they also provide us with the app platform. We use our own content and coaches, but it's their platform. And we have a qualified, highly experienced GP medical director who's been involved in this arena for some time, and she reviews all the potential significant side effects or adverse events or threshold breaches, which I'll comment on in a minute, before we send any notifications back to you to make sure that we're not bothering you with unnecessary correspondence, but focusing on the important side of what's important. So who's the service for? I won't go into this in huge detail because you'll have the slides, and it's featured in a range of different formats. But there are a couple of things which I'll just draw your attention to that you might not be expecting, and also which seem to cause some of the most significant causes of people sending us referrals that are not eligible for the service. And unfortunately, if people aren't eligible according to these criteria, we have no choice but to send them back. So just to highlight a few of those, there's an upper age limit of 65, and the type 2 diagnosis needs to have been within the last 6 years. And that is, that's to a lot of these criteria are to mirror the direct criteria, so the results can be compared. On the HbA1c side, if people, and these would be probably what you'd expect, but if people are on medication, diabetes medication, then HbA1c of 43 or above, and if they're not yet on any medication, then 48 or above. And in all cases, there's an upper limit of 87, again, to compare it direct. Insulin, as you'll see, is an exclusion criterion, as you'd expect. There are a range of other exclusion criteria that you would probably expect as well. But in addition to the specific criteria, there's also your own assessment as healthcare professionals. So if you don't think that it's going to be feasible to safely and robustly monitor medication adjustments or your patient's medication for any reason, whether it's that, for example, sometimes medications are prescribed from secondary care and need to be monitored there, but if you don't think that's going to be practical on an ongoing basis, then, or for other reasons that pertain to safety, then it's best not to refer that patient, particularly at this time. It might be that it becomes more suitable later, or it's just not appropriate. So there's some very specific criteria, but there's also your assessment as healthcare professionals. I won't go into this in huge detail, but you can just see that the three phases of the service in different colors. So the total diet replacement for 12 weeks. And in this phase, the sessions start off weekly and then go fortnightly. Then over the second phase of rebalancing, there's an extra one, and then they're fundamentally fortnightly. The extra one just because that phase is it's the most challenging for people, so we want to give a little bit of extra support. And then the third phase of weight maintenance, where, as you can see, the topics start to focus more on nutrition and physical activity. Can't talk too much about nutrition in the first 3 months when people are on shakes and soups. It's not very friendly. So it focuses much more on the behavioural support and psychological tools to keep focused on that goal of getting to the 3 months. We provide lots of different resources. We think, actually, I mean, I know everyone will say this, but we really do think they're really good. Huge amount of effort's gone into developing them, making them as interactive as possible, whether that's on the app or whether it's the in-person resources and workbooks. In terms of the products, there's a choice of 10. 2 porridges. Banana porridge is scarily popular, given I'm a bit of a porridge purist, but banana porridge seems to be very popular. And there are 5 shakes and 3 soups. They're all vegetarian, they're all gluten-free, and 4 are vegan. So they're suitable for most. There's something in there that will work for people on most approaches, dietary approaches. We provide participants with voucher codes. They order directly from that website. We send them samples in advance of their first order so that they can get a feel for what they're looking to order. And they also get a shaker with their first order. And they get different voucher codes as they go through. So they order about a month at a time, and there's no cost to them. They get it delivered to their preferred venue, be that home or work or wherever. Just to give you a very brief overview of some of the resources, these are for the in-person delivery, so they get workbooks, trackers. There's an XC app as well as pedometer, wallet cards, access to an online recipe book. And on the app side, again, I'm not going to go into this in great detail, you'll be glad to know, but just to give you an idea, it's quite a clean, easy to use, intuitive interface, and it's all the things you'd expect in terms of seeing the different content and how you kind of mark the lessons as complete or the sessions as complete. And then it's also got some gamification built in there around getting rewards, so people can earn habit coins and qualify for rewards, which include like Amazon vouchers and things. So away from the program, onto the roles and responsibilities. Fundamentally, we obviously need referrals from you, otherwise we have no one to deliver the service to. So we've worked with the ICB to develop some support to help you get to those referrals as efficiently and helpfully as possible. So there's some patient information leaflets, landing page, practice poster. There's an animation if you want to use it or send it to patients in advance or potentially eligible patients in advance of maybe the landing page. We can support you with drop-ins. So some of you saw John earlier and Keris. Keris in particular will support with any, if you want to have drop-in events and extended group consultations at the practice, we can support with that, and also attend other events and meetings to talk about the service and help highlight how to refer to it. The referral itself will involve, at the very least, a patient appointment, with which we'll get onto in more detail in a minute, and then you filling out a referral and medication adjustment form, sending it to us, and providing a copy, at least, of the medication adjustment form to the patient. Once, and again, we'll go into that in more detail in a minute. Once you have sent that to us, we will do an individual assessment. We'll register the participant and check that they're eligible, etc. And when they've done their individual assessment, they will make a choice as to whether they want to do digital or in person. And then we'll either put them on a nearby clinic or put them on a waiting list until we can get enough people to put a small clinic on in an area. And we will proactively go out to nearby practices to ask for additional referrals if we are seeing 2 or 3 people waiting a little bit for a clinic. It's not like a group. We don't need 15 people in the same place, but we do need at least a handful. Then we run the 3 phases of the program, and during that, that kind of service delivery phase, at each of the sessions, or for digital participants at each of the session equivalents, we monitor a number of different things. So obviously attendance and that side of stuff, but also we monitor blood glucose for all participants, blood pressure for those on blood pressure medications at the referral, BMI, significant side effects, and adverse events. If people's readings are outside of thresholds or they experience significant adverse events or side effects, then we will contact you and let you know. We'll come on to that in more detail in a minute. But again, that's also why the first phase, having weekly sessions at the beginning, is important. So you can get those. We can get those measurements more frequently, and so we can see if there are, people are not responding as they should be. Just saw a question about where the clinics. They're not actually there yet because we haven't got any referrals. But John and Keris can probably give a bit more detail about where they're likely to be. But it depends where the referrals come, and we've got a range of different venues that we can use, and we'll cluster clinics. Oh, sorry, we will put clinics on where there are clusters of referrals. We're very happy to get suggestions of clinics from you on the way if you think there's a particularly good place to use for your patients, and also some practices would like us to actually have in other areas like us to deliver the program in their practice, because it's a one-to-one service, and so it just needs a consultation room. And if you want to do that because it's helpful for your patients and also potentially for you to see them for other reasons, then we're very happy to just get in touch with John and Kerry at the end. And other TDR sessions, group sessions, no, the whole service is one-to-one according to this specification. During the program, the only things that are in your court in primary care are repeat HbA1cs at 6 and 12 months, and also medication reviews if required. So if we report a threshold breach, which John will cover a little bit later, then we'll recommend a medication review, and so that would be important to do that in a timely manner. So briefly, in terms of identifying interested patients, there are 3 basic ways. One is by a search of your register for potentially eligible participants, screening the search results, and then sending a text or potentially letter with either a link to the landing page which tells your patients more about the service and encourages them to get back in touch with you if they're interested in having a referral and discussing a referral. Second is in usual care. So either on diagnosis or an annual review, or possibly on patient request when they're coming in to see you about something else. And thirdly is a more customized version. So this is something which some practices or even at PCN level, if they think that there are a lot of patients who are likely to be eligible and interested, then they might be interested in doing a group consultation. So it can be a more efficient way of doing it. It can tick other boxes like enhanced access because they're best done in the evening from the feedback we've had from other places. And we can again support with those and coming to talk about the service or providing samples of shakes and stuff. If you think there's going to be lots of people, then it can be quite efficient from getting the medication adjustments done and that information sent. But some people prefer to do it just in usual care, and others do a search and invitation. This is probably the most relevant for your patients because they're thinking about their diabetes at that point. And this is this one, or potentially the group consultation approach, is probably the most efficient from your point of view. So I mentioned patient information leaflets and practice poster. There's the link to the animation there as well, and a link to the case study page. So when you get these slides, it's worth having a quick look at some of those. The patient information leaflet is just a couple of sides of A4. We have some copies, or you can print them. The poster is one sided A4, same thing with a barcode to take to the patient stories. Yeah, there's obviously you can click on those links and find more information. All right, so now I'm going to hand over to John for the medication adjustments piece. Thank you very much. And if I miss the slide timings, just shout at me.
Great, thanks. Hello everyone. My name is Chong Oye. I'm a consultant in diabetes in Aintree and also the clinical lead for the Cheshire and Merseyside Diabetes Network. Can you all hear me? Can I just check that? Yeah, it's okay. Thanks, Harry. So, as you can see, people on the program can achieve a significant amount of weight loss and in some cases go into remission. So it's very important that we look at their medication at the time of referral. The original studies from, I think, 10, 12 years ago now stopped all medication. And we've got a similar approach, but not quite. It's easier, of course, as physicians to start people on treatment, and it's a bit harder to think about trying to stop medication. But we have to remember that people are going to actually be on half their normal calorie intake in a day. So there's a significant drop in terms of what they will be having as intake. And they really often don't need much of their diabetes medication at all. So the the recommendations that follow in the next few slides are based on the direct study. They are slightly more cautious. Direct would have stopped, I think, all medication at the initiation of the meal replacement products, but we're not suggesting that you do that. So it's slightly more cautious. The guidance, however, doesn't replace your clinical judgment. So if you're unsure, then either you may feel it's not the right person to refer, or consult with a colleague who can provide you with maybe a second opinion or more sort of experience. Next slide, please. Basically, if your patient is on no agents, then that's not an issue. And this is, we're talking about glucose-lowering agents here. If they're on 1 or 2 agents, then we suggest that you stop all the medication at the start of the total diet replacement. If they're on 3+ agents, then we suggest that they stay on metformin, or if they were intolerant of metformin, their first-line medication, and this is usually going to be a DPP-4 inhibitor, usually. But we suggest that with 3+ agents, they should stay on at least 1 agent, because there's a likelihood that they may not go into remission and their glucose may continue to remain high if they have no medication at all. Unfortunately, being on insulin is an exclusion. So it will be of some disappointment to patients, because I know that certainly I have a whole caseload of people who wonder if something like this would make a difference, and the answer it probably would, but Momenta and the program is not set up to help with insulin titration, and we certainly think that stopping insulin completely for some of these people may put them at some risk. Harry, do you want to mention anything about the medication adjustment form at this point?
I think no, other than just to say we'll refer to it quite a few times over the course of this, and then we'll take you through the referral and medication adjustment form a bit later. So don't, it will make sense when you see it, but fundamentally it's where you record the adjustments that you're requesting your patients make on the first day they start total diet replacement. So it's really important to just emphasize that they don't start it after their appointment with you, they only start it on the first day they start taking the total diet replacement products.
Yes, I think that answers Danielle's question. So they don't stop it at the point of sending the referral, they stop it at the point at which they start their first day of their total daily replacement. Next slide, please. So which glucose lowering agents are safe with total diet replacement? I suppose anything that doesn't cause hypos generally. So definite no-nos are sulfonylureas and the thiglinides, because they can all cause hypos. SGLT2 inhibitors generally don't cause hypos, but because there is a risk of ketosis, we would not recommend that they remain on those agents while they're on total diet replacement. And GLP-1 analogs, while safe, we tend to also suggest that they don't stay on them, simply because you are trying to achieve weight loss or total diet replacement. And you kind of think, well, if the idea behind a GLP-1 receptor agonist is to reduce dietary intake, you don't need that really when you're on total diet replacement. When do you restart glucose lowering agents? Well, if the Momenta team flags to you that the blood glucose is over 15, or that your HbA1c at 6 to 12 months has risen, then metformin may need to be reintroduced. And other options also might be pioglitazone or DPP-4 inhibitor, again, because there's really no risk of hypoglycemia with those agents. At any time, really, we suggest that sulfonylureas and the meglitinides or SGLT2 inhibitors should not be used while someone is on total diet replacement. If the patient requires insulin initiation for whatever reason, then unfortunately they have to leave and fall out of the program, as previously mentioned. Right, blood pressure lowering agents. This depends very much on the blood pressure at referral. If the blood pressure is raised and over 140 systolic or over 90 diastolic, then no change is required in their current blood pressure medication. But if the blood pressure is in range, then we would suggest that we look at which blood pressure treatments are specifically for hypertension and not for other indications such as heart failure or rate control in AF, for example. Patients should be told that there is a risk of postural hypertension because of their diet will change and they'll lose weight. And we would normally suggest a reduction in their blood pressure medication if it's purely for antihypertensive treatment. Next slide, please, Harry. And which ones would you stop first? Well, you would stop them in reverse order from the NICE guidance. Okay, so NICE tends to say, certainly for people with diabetes, which is this cohort, you start with an ACE inhibitor or an ARB, then you follow it on with the calcium channel blocker or thiazide diuretic, and then so on and so forth. So when stopping one of those agents, you would go backwards. So if the last introduced agent was an alpha blocker, then you should stop that and retain the calcium channel blocker and diuretic and ACE inhibitor. Or if the patient is a combination of an ACE inhibitor, calcium channel blocker, and a thiazide diuretic, then you might stop either the calcium channel blocker or the thiazide diuretic. But just bear in mind, once again, if the patient is on these agents, not just for blood pressure, but for other indications such as heart failure, then you need to retain those. So subsequent blood pressure agent adjustment. If the blood pressure is too high, then you would reintroduce the agent that you stopped. If the blood pressure is too low, then once again, you would stop in reverse order the blood pressure medication that was introduced previously purely for blood pressure treatment. Next slide, please, Harry. There are, of course, other medications that may perhaps weight-based and may be changed by the patient's weight dropping. So you need to maybe look at the rest of the medication and say, is anything there something that I would normally adjust if someone's weight was going to drop substantially? In general, they are, the next slide, please. That might be warfarins, the DOACs, perhaps digoxin, phenytoin, some antifungals, and long-term therapies such as low molecular weight heparins and antibiotics. I think that's my bit there. Are there any immediate questions? No.
Covered beautifully, clearly.
Reasonably straightforward. Thank you.
Exactly, and again, thank you very much for that, Chung. And I'll just say that it's back to the overriding experience that we've seen, continuous stacking, Gareth, is that the majority of referrals are relatively straightforward from a medication point of view, not least because of the upper age limit of 65 and the relatively recent diagnosis within 6 years. There are obviously exceptions. This guidance should cover the majority of it. If there's things which aren't clear from the guidance, then please contact us, not me, I hasten to add, but our medical director or Chung. And also, if you're unsure, then it's safer not to refer rather than to refer to this service. And there are other options available which can help your patients. So I think we just emphasize that last point. Sorry, Gareth, over to you.
Yeah, with regards to stopping blood pressure tablets, is that again on day one of doing diet replacement, or is that beforehand?
All the medication adjustments are to be made on the first day of total diet replacement products, not beforehand. And the reason for that, well, there's the reason was in the very first slide, which you'll see when we send these around, which had the graphs of what happened to people's blood glucose levels and blood pressure levels after starting TDR. So there'll be no change until they start TDR, and so therefore it wouldn't be safe for them to make the change immediately. And the other question that's related to that is from just coming in the chat, is that they will be making their own medication adjustments based on the medication adjustment form in the referral form that you will provide us a copy with and them a copy with as well. So if they are, it's really important that they are understand those changes in your appointment. If they don't, then we'll have to send them back to you. We can remind them if they just need reminding, but we can't if it's completely unclear to them. We have to send them back to you to have a refresher on that front. John, go ahead.
I was going to say, perhaps we should dwell on the first slide a bit more. I think that the drop in blood sugar is no surprise, and it's a no-brainer, really. But thank you, Harry. But the drop in blood pressure is fairly significant. I mean, it's equivalent to at least a single agent, if not more. And it happens quite quickly within the first week of treatment, and then sort of stabilizes out. So you tend not to worry about a continuous drop, over the next few weeks. But within the first week, you get that drop, which is probably equivalent to at least a single agent. Thank you.
Thanks. There's a couple of other comments in terms of around this. So how often are they monitored? They're monitored if they're in person at each clinic, or if they're digital at each clinic equivalent, kind of same length of time scale. We send them a blood glucose monitor, strips and lancets, and also a blood pressure monitor if they're on BP meds at referral. Unless they've got their own that they use already. So there's no need for you to prescribe additional strips or lancets, but they will be, if they don't respond with those, if they don't attend the sessions, or if they don't respond with those measurements for digital participants, then we will have no option but to discharge them. We'll obviously let them know that first, but we'll also let you know as soon as that happens, and let you know at what stage in the program they are being discharged, and therefore you'll be able to, and whether a kind of medication review is important quickly or not. And there's another question about how often are they monitored at each session? The sessions vary in frequency. So at the beginning, they're weekly for the first 4. Then they go, if you think about it, being fortnightly up until about 4.5 months, and then they become monthly. So that's just a very rough rule of thumb. But in the first phase and the first month is when they will have the steepest weight loss, assuming they follow the total diet replacement. I think, is the onus on us to stop these, or is it checked on commencement? So the onus is not on you. The onus is on you to make the recommendation and the guidance to the patient. We will reinforce the need to stop the medication on that first day of total diet replacement, and we will not just tell them that beforehand. We'll check with that in the session, or on the coach call if it's digital. So we'll check as much as can be checked. And again, if people are unsure, then and they don't remember it at all, then we'll refer them back to you for checking. If they don't engage, so a question about if they don't engage or follow the regime, how quickly do you let us know? So if the non-engagement is prior to them starting, then we won't let you know for a little while, because we have to try to engage them in various different means. However, they should not have made their medication adjustments at that point, so there should be no safety issue particularly. If they start the program, start the total diet replacement, and then they do not attend 2 consecutive sessions without a good reason, then we will discharge them and let you know. So at the beginning, that is within 2 weeks, and later on it's within 4 weeks or 2 months. But in the 2-month period, they shouldn't be experiencing significant changes, apart from potentially their weight might be increasing, and so they might need a medication review. But we'll let you know as soon as they've not attended 2 sessions. We will provide you with details in the referral form shortly. In fact, John, I will hand over to you for talking through how to make a successful referral. And thank you for your questions, I should say. It means that it runs slightly longer, but it's much more engaging and much more interactive, so we really appreciate it.
No, thank you. It does make for a really interactive session, and I was furiously trying to type, and then I thought, oh, Harry's covering these now. Anyways, so if you do need any written clarification, there's quite a few questions on slides, which between Keris and I, we will send you post session. So in terms of making a successful referral, Harry went through the 3 different core methods of referring patients into the service, being the ad hoc approach, the search and invite, and the more bespoke approaches. We do have a range of tools and resources that are available, and I will pop in the chat very, very shortly our referrer webpage, which will also be included on a subsequent slide as well, to support you with identifying and inviting eligible patients into the service. Once you have identified and invited eligible patients, thanks Harry, here's one we prepared earlier. This is the referral web page, which we will include in the chat, which has lots of key information about the service. A lot of what Harry, Chong and I are going through is already included on the referral web page. And there was a question earlier around inclusion exclusion criteria that is also included on the referral web page. Once you've identified eligible patients, the next step is to do a referral appointment and complete the referral form and medication adjustment form. We have lots of evidence around how this works in practice and some real cracking examples of how succinct primary care could possibly do this to send lots of patients very, very swiftly. Typically, though, the appointments to explain the programme and the service and do the referral form and medication adjustment form is typically 15 minutes. And I think I'll just reiterate again, just explaining to the patient that all medication adjustments will need to start on day 1 of total diet replacement and not before. We will also reiterate these messages at various points throughout the onboarding process of getting the patient into their desired delivery format as well. And also please provide a copy of the medication adjustment form, not only to us but to the patient as well. It can often delay things a little bit if a copy of the MAF isn't provided to the patient. And then once everything's completed, the final step and the easiest step is just send us the referral form to our nhs.net account. It's C and M, not C M, but C and M, just to ensure you get that right. But it is in the NHS directory, so send all completed referral forms to us to process. Once we do receive the referral form and it is processed, we will send a receipt of referral back to the email address that it was sent from, and we will also give the SNOMED code as well of how to with what you need to code the patient with. If the referral form is missing any key piece of information, we will also request that from you upon receipt of referral before we can sort of complete that referral form and begin getting in contact with the patient. Thanks, Harry. Searches, our colleagues at the clinical network are working with the CSU on getting screenshots of where the searches and the referral and medication adjustment form are located, and we will be including those screenshots once received in the slide deck that we will send out. And then finally, the referral form. So after delivering this service for 4 years now, we have lots of evidence and feedback over the referral form and how to make this as straightforward and seamless as possible. So can you scroll down, Harry, please? Sorry. So the obviously, as you would expect, sort of the patient details, your GP practice, and the referrer name as well should be included in the top section, as well as the declaration. So please ensure that that is read and understood. We've also got a box of who has signed off on the medication adjustment form, that is a real key piece of information. So if it is somebody different that is not completing the referral form, then please input their details in case we need to check in on any of the meds, and ensuring that the patient fully understands the medication adjustment form. As people, some of our team are non-clinical, we will never advise on what meds or meds adjustments need to happen. All we can do is reiterate what is on the form. So if the patient is requiring further clarification, then we would request that they would contact the practice again.
And the reason, just to add to that as to why this box is here, is that different practices refer to the service in different ways, we've found, and it depending on their own levels of staffing and how they're used to working. So they might well find that someone who is not a prescriber might be best positioned to talk about the service as a whole to the patients, and to do more of that initial discussion and to fill out much of this form. And in which case they would need to work with a prescriber to sign this off, or they might even be, for example, a diabetes specialist nurse and a prescriber who is not signed off to prescribe or deprescribe in this case on blood pressure medications. So again, would need just a review either from a GP, from a qualified prescriber, be it GP colleague or a pharmacist. So it just allows for a bit for transparency over different ways of managing the work in your practice that works best for you.
Thanks, Harry. The next section is personal details and information, and then there's some key pieces of information in this section that we will need to ascertain. Eligibility, the inclusion exclusion criteria, things like date of diagnosis is a really important one. And just as a reminder, date of diagnosis needs to be in the last 6 years. Weight, height, BMI, the HbA1c, and the criteria for HbA1c is highlighted around what would be eligible. The blood pressure measurements, and then finally sort of checkbox on learning disability, the SMI register, and any relevant disability that that we need to be aware of.
And we should probably have said that all these bits that look very unfriendly in grey are just because that's what will auto-populate from EMIS. So the vast majority of the form, before we get to the medication adjustment bit, auto-populates from EMIS with a few checkboxes like here and down here for manual entry. But the rest of it is this all will pull through.
Cool, thanks, Harry. And then we do include the inclusion exclusion criteria just for primary care to do a bit of a sense check to ensure that the patient is eligible and appropriate for the service. And then we have further guidance on the medication adjustment form. So the current list of medication should be included in the referral form as well, and this should be pre-populated as well, the current list of meds. And then the next section is the medication adjustment forms. This has been a recent addition which has proved really helpful to a number of clinicians, which is surmising the medication adjustment form that Chong very helpfully went through earlier around what to do with various agents. Then the medication adjustment form itself is a series of checkboxes, again, with the medications. Is the patient on any diabetes medications, blood pressure meds, and then any other meds which may need adjusting, which may cause changes in weight. And then finally, the medication adjustment form itself. So this will require completing around the meds that the patient is on. The next step is the action, whether to continue, stop, or reduce. And then finally, the specific changes that do need to be made on the first day of the meal replacements.
And also to say that these things that say NA here will be drop downs on your EMIS forms or System 1 forms. There are, you can't see very easily in this Word document, but you'll see that there are drop downs which have the relevant medication name, so you don't have to retype it every time. So the idea is it makes your life a little bit, you've still got to pick it out of the drop down, but it makes it a little bit easier and a little bit time saving, and that's a result of feedback for it previously. Yeah, and then there's some more information at the bottom, as well as the SNOMED code for referral. And the QR code links to the participant webpage. So if you're doing this in practice and you want to give someone, you don't have a flyer to hand or the website, you can just get the patients to look at that on with their phone, and they can go to the webpage to look at later. And just maybe quick before we go back to the presentation, just to recap, it's obviously a lot here in many ways, but if you look at it as a whole, there's a few bits on the first page which largely auto-populate, plus the instructions, and I'm making this deliberately very small, sorry, I should have said, so that we're looking at it as a whole. There's then a section here which again is most of the patient information that largely auto-populates. This next 2 pages are all for your reference. So it's got the eligibility criteria, it's got pulls the current and repeat medications, so you don't have to go back and forth between systems and windows. You can have all the information in this document to make the medication adjustments, and this flowchart which summarizes the protocols that John talked about, followed by some checkboxes, and then only obviously selecting the medications that need to be adjusted, nothing else, to make it clear. So although it's a long form, the actual pieces that need your manual intervention are relatively limited, and there's quite a lot there for reference. We initially had a shorter form, but we included the reference pieces from after feedback from people in other ICB areas from primary care. If you don't want them, we can always change them back out again. But they do seem to have been useful on the whole. Interest of time, John, I'd suggest we probably skip through these because you'll have the slides afterwards. And John's covered most of these as well, both in the form particularly, but also in the searches. This page here, we won't go through in detail because it's basically the service on one slide as a summary. So you can keep it or print it off, and it's also on the Referral resource page if you want. It has all the supporting links and contact information for us. The 2 key ways of identifying patients. We put the 2 SNOMED codes here that we won't know about. So we won't know if you've invited anyone until you refer them to us, and we won't know if they've declined after being invited. So they're both here for you. Everything else we will send to you at the relevant point of the service or when we get the referral. There's then the 15-minute appointment, our checks, onboarding, and actual delivery of the program, discharge at the appropriate point and when we inform you, and then the pieces we do that John referred to. If the referral form is incomplete, then we'll come back to you requesting any updated information, and then also if in the monitoring, we find people breach any of the thresholds, we'll let you know. And there's also the repeat HbA1 6 and 12 months. So that's kind of the service in one page as much as we can as an overview. And then just in terms of key contacts, these are John, who you've seen, Keris, who is there and was on at the beginning, and Dr. Ellen Fallows, our medical director. Keris and John's emails are here to click, and from the ICB side, there's John, and Beth was also here at the beginning, I saw, who've been extremely helpful in getting this service up and running. Next steps are we will send you the pack, the slides, the resources, the web links, This is the referrer page, but that we flicked through beforehand, but we'll send you that afterwards. Please let any of your colleagues know about the service. We'd be most grateful for their and your referrals, and also attending any other events you'd like us to attend, either in practice or in a PCN level or other sessions. John and Keris have attended some already, and probably met some of you here. Apologies for me not having done so, but they will continue to do so, and we look forward to working with you. And again, just the prompt about venues, if you have any, if you would like us to deliver the service in your practice, please do let us know, and we can arrange that with you. So I'll stop sharing now, but please, and I know the time has officially come to an end, so John, you can probably stop the recording, but we will we'll stay on to answer any questions you might have, if any of you can stay on, but no, won't be offended if any of you disappear. And we'll start to work through the ones in the chat at the moment. So in reverse order, it is a lot to digest, thank you.